so Meredith Clement is here from LSU in New Orleans, and she is going to speak to us about this emerging scourge, recurring scourge of syphilis. We've seen our numbers go up. She'll talk about this. She'll talk about what's happening in congenital syphilis, but what are we going to do about this? We have shortages sometimes of bacillin, and what are we going to do with that? I'm looking, you're here. Okay, good. Yeah, so come on up, and it's great to welcome you here. We're really looking forward to hearing an update about this because, I mean, I don't see many cases of syphilis, do you? Yeah, like every day. Okay, so welcome.
Yeah, thanks. Okay. Great. Yeah. Okay, so thanks so much. I'm so excited to be here. This is a fabulous conference. And so the title of my talk is Diagnosis, Prevention, and Management of Syphilis. A lot of good information, and so I'm hopeful that you will find that true. These are my disclosures, updated end of October, but current through December 4th of 2023. And so here are the learning objectives of the talk. So after attending this presentation, you as the learner should be able to describe recent trends in syphilis epidemiology. And as Dr. Sag was just saying, we've seen recent tremendous upticks in congenital syphilis, maternal syphilis. And so I'm going to touch on that for a second because I just think it's incredibly important for us to all be aware of. Secondly, to discuss the diagnosis of syphilis and clinical findings in persons with HIV. So this is the Ryan White Conference. Of course, we're focused on persons with HIV. And if your practice is anything like mine, we sadly do continue to see uncontrolled HIV patients coming to us with severe immunocompromise and having more severe manifestations of syphilis. So I'll focus on that for a bit too, and then finally talk about the management of syphilis in the setting of recent drug shortages. Specifically, this refers to, as Dr. Sag just said, benzathine penicillin G, which we've suffered a shortage of since this summer. And so you may have seen a slide like this before. This is what's put out by the CDC every year that just gives an overview of where we are with STDs or sexually transmitted infections in the United States. And 2021 is the year for which we have the most reliable finalized data. There is some preliminary data from 2022, which I'll touch on in a second. But really just to say, chlamydia, we've seen a small decrease since 2017, but really we think some of those numbers are not totally reliable because of the pandemic. Whereas with gonorrhea, a 28% increase since 2017, with syphilis, a 74% increase since 2017, giving us 176,000 cases in 2021, and then almost 3,000 cases, sadly, of congenital syphilis, which, as many of you know, can be very devastating, leading to stillbirth and fetal demise and other grave consequences. So these are the 2021 numbers. Altogether, this was about 2.5 million sexually transmitted infections in the United States in 2021. Okay, and so focusing specifically for a second on primary and secondary syphilis, there were about 55,000 cases in 2021. You can see here, here's the cursor. So still predominant number of cases among men who have sex with men, and really the CDC does not give great data on transgender, non-binary, other individuals, so they really break it down according to sex and the type of sexual partners. But so for men who have sex with men, still the predominant number of cases. But what you can see is cisgender women had an uptick. So the increase of cases among cisgender women was by 55% going from 2020 to 2021. So now they make up the second largest demographic group. For primary and secondary cases, those are the most infectious cases, which are actually easiest to track. And so in parallel with this increase that we've seen in cisgender women, we also have seen a tremendous rise in congenital syphilis cases. And so here's where I mentioned the preliminary data for 2022. Now 3,500 cases of congenital syphilis in 2022. And the kind of associated statistic with that number is that over the past decade, we have seen a 900% increase in the number of congenital syphilis cases, if you include the 2022 numbers. So with that really positive introduction, I want to jump into a case. So this is a 44-year-old cisgender male. He has uncontrolled HIV, so his CD4 count is 98, associated with 6%. Viral load is 64,000. He's not currently on treatment. And so he comes to you complaining of 1 month of fevers, weight loss, and these sores. And what you can see are these large ulcers with kind of this keratotic or crusted surface appearance. He tells you these lesions are painful and they're also itchy. RPR, you're thinking about syphilis, so you get an RPR, but it's non-reactive. So in this case, what is your next step? So I'll give everybody a second to kind of think through that. I guess I'll say the answer choices: A, bring the patient back in 2 weeks for retesting; B, ask the lab to dilute the specimen; C, biopsy the lesion; or D, refer to dermatology. Can always count on Dr. Sag for the best music, right? Okay, maybe I'll give it just another second. Two. I hear some chatter, so maybe there's some discussion of what the next best step is. All right, okay, I think I'll move forward. Okay, so the predominant response was biopsy the lesion, which I think is not necessarily incorrect, but not what I was going for. The right choice in my mind is to ask the lab to dilute the specimen. If you, some of you, 32% have tremendous clinical acumen and they're thinking, this is secondary syphilis. I really am suspicious of this regardless of the RPR result. So I'm gonna ask the lab to dilute the specimen because I'm concerned about prozone phenomenon. So I'll talk about that in just a second, but first I want to talk about the lesions. And so this is malignant syphilis. Again, it's secondary form of secondary syphilis. It's uncommon. It is seen more commonly in immunocompromised persons, so like our patient with a very low CD4 count and immunocompromised. This is also called Louis maligna or ulceronodular syphilis. The diagnosis of this was so exciting, or this is just such an exciting clinical manifestation of syphilis, that malignant syphilis was actually the clinical image for the New England Journal in both 2022, so the image I showed you before, and this image of 2023. And what you can see here actually is these necrotic ulcers that have this oyster shell crust, which I think is a very apt description. But generally, this is a papulopustular eruption that over time can evolve into painful necrotic ulcers. And malignant syphilis is actually often accompanied by systemic symptoms, so fever and weight loss, like in our patient. They can have headache too, but I don't want to throw that in and make people start thinking about neurosyphilis. So the prozone effect, or the prozone phenomenon, you may be aware of this. It's when there are really high antibodies, so this overabundance of antibody can interfere with the formation of the antigen-antibody complex, a process we refer to as agglutination. And so this clumping process is not able to be visualized by the lab tech, and therefore the RPR is documented as non-reactive. It's rare, but it's associated with pregnancy, HIV co-infection, and neurosyphilis, and some labs actually know to look out for this, so they will test for prozone phenomenon in all patients with HIV. So what you can ask the lab to do is to dilute the specimen if you're concerned for this process in order to help visualize agglutination. So you ask the lab to dilute the specimen, and afterwards the lab reports that this patient's titer is 1 to 1024, which you will often see a very high titer in these cases based on the sort of process I just explained. As expected, the treponemal antibody testing is also reactive. So you thoroughly question the patient. He has no neurologic symptoms. You actually bring him back for a physical exam. He has no other exam findings of concern. And you would like to proceed with treatment, but your understanding is that there is unfortunately a penicillin shortage. And so in the current landscape, the doses are being reserved for women, or for persons, I apologize, who are pregnant or potentially could become pregnant. So how would you treat this patient? I guess I need to click forward. Okay. So would you give A, 7.2 million units of benzathine penicillin G? This looks like very severe disease. You don't care about the shortage. B, doxycycline for 14 days. C, procaine penicillin plus probenecid for 14 days. Or D, amoxicillin for 14 days. And I want to add one quick thing that I forgot to mention with the first case, that bringing the patient back in 2 weeks would have been an appropriate response if you were concerned for primary syphilis in the setting of a chancre, but that patient had secondary syphilis, where you really would not expect a false negative RPR related to just late seroconversion. So for this, we have 97 responses, so I think I'll move on. Okay, so doxycycline for 14 days. So this patient has secondary syphilis. Doxycycline is our preferred alternative treatment in the setting of the bicillin shortage or the BPG penicillin shortage. Procaine penicillin is actually no longer manufactured, so that is not an answer that we would pursue. Again, 7.2 million units, we use that for late syphilis, but not for early stage disease, which this patient has given their secondary syphilis. And then amoxicillin for 14 days, I'll talk about some data for that in a second, but that's really not a preferred treatment regimen here. Okay, so the shortage of benzathine penicillin G, which I will say BPG or perhaps bicillin, which is the trade name. I just want to distinguish bicillin LA is what we use, not CR. CR is not appropriate to use for syphilis treatment. So BPG is the recommended treatment for syphilis. It is the only recommended treatment for pregnant persons infected or exposed to syphilis. Pfizer is the only manufacturer of BPG. So when Pfizer is no longer producing penicillin at the rates we need, we have a shortage. And Pfizer also, as many of you are probably aware, had a manufacturing delay of BPG from 2016 to 2017. And I will credit Western Chic Designs with this image of the desert, but just to say not our first rodeo and emphasize that we've dealt with this before. There need to be systems in place so that we don't have to deal with it again. Okay, so what are we doing about it? So the National Coalition of STD Directors, or NCSD, has written a letter to urge the White House Drug Shortage Task Force to prioritize action to end the ongoing shortage of bicillin LA. Currently, the shortage is not really anticipated to end until the second quarter of 2024. Where I am in my clinic, and I'd be interested to hear everyone's experiences in the room, for a while we were in very short supply. We've more recently come into more bicillin, so we're able to use it with more flexibility now. But I think it's been a struggle, and I guess I'll get to a survey in a second from NCSD about the impact on clinics. But the CDC has offered a bit of guidance to kind of let us know what to do during this time. They've asked that we monitor doses, we request additional doses when needed, that we really preserve or reserve BPG for pregnant persons with syphilis diagnosis or who have been exposed to syphilis. And then just in terms of staging, to really do a thorough physical exam to look for chancres that may be present so that we can treat for primary syphilis with 1 round of injections rather than 3 and avoid unnecessary use. And so here's the survey I mentioned, but the quote was, the bicillin LA shortage is having widespread and direct impact on sexual health clinics getting the drug they need for patient care. And so this survey was done in September. There was another one that was just completed, but I don't have those updated results yet. But they surveyed clinics across the country that do sexual health care. And what they found was 40% of clinics have attempted to order BPG, but found that the drug was not available to them. 28% had to obtain BPG from a nearby clinic or refer patients elsewhere, and they found that that's associated, as you would expect, with delays in treatment. And then clinics also just reported increases in time they spend on different tasks, administrative tasks, trying to track patients down for follow-up of syphilis, and then just overall on patients diagnosed with syphilis in the setting of the shortage. So now I just want to talk for a second about a systematic review. I worked with some colleagues to complete this back in 2014. And really the 2 things I want to point out are just in terms of treating syphilis with non-penicillin regimens, not much has changed over the past decade. And the reason I show this paper is because we actually graded the evidence, the quality of the evidence based on the American Heart Association classification. So I just want to include a table from this study that we did, this meta-analysis, with early syphilis, and I'll just highlight here, being primary, secondary, or early latent syphilis. Those are the only stages of syphilis for which there's a grade A recommendation for treatment, and that grade A recommendation is only for 2.4 million units of BPG. And sorry, I misspoke. There's one others, but it's azithromycin based on large clinical trials that meet the standard for grade A quality of evidence. But as you know, we cannot use azithromycin in the United States because of macrolide resistance rates of approaching 50%. So we don't use azithromycin. I want to point out the alternative therapy that is preferred now, which we're all using, which it sounds like you are very aware that we're all using, is doxycycline. And the grade of evidence for that approach is B. It's really retrospective studies, smaller studies, and our history of clinical experience with doxycycline. So I just want to touch on a few newer studies that you may be aware of on different medications that we're not used to using for syphilis. The first being Syphilis. So this was a study conducted by Jeff Klausner and colleagues, published in CID a couple of years ago. They called this a randomized open-label non-comparative pilot study. And so it was small, but it was randomized. So it was 400 milligrams of twice-a-day Syphilis for 10 days versus BPG. They had 50 participants enrolled, and so when they got to the per protocol analysis, that really is quite small, 15 patients per arm. But the treatment response per protocol was 93% with BPG, 87% with Syphilis. Intention to treat was quite lower, 81% versus 57%. But this has kind of laid the groundwork for further studies that are ongoing with Syphilis. And then I'll mention amoxicillin with probenecid. This regimen is listed as an alternative treatment regimen in the UK. I think based on some pretty limited data, this regimen is also used quite frequently in Japan, where they really don't have access to BPG much at all. And so this study was published in 2015. It was retrospective with no control. But for the patients who got 3 grams of amoxicillin and probenecid, the overall treatment efficacy was 95%. So quite high. And then really very recently, just a couple of months ago, there was a larger study looking at combination high-dose amoxicillin, so 3,000 milligrams daily with probenecid, versus low-dose amoxicillin monotherapy. This was 112 participants, so there were 56 participants in each arm. The serologic cure rates were high. They looked at these at 12 months, so 90.6 with low-dose amoxicillin and 94.4 with the amoxicillin probenecid regimen. I'll say the rates of cure were even higher in the early stages, which we tend to see, and it was, I think, 85 to 87% of the patients in this study had early syphilis. What they did not show, or what they were not able to show, was that the low-dose regimen met the non-inferiority criteria. So, but that said, the overall rates were very efficacious, and so the authors argued that this regimen could or should be potentially studied further as a comparison to BPG. Highlighting some of the recent studies, these are all published between 2016 and 2022 to consider doxycycline or minocycline for syphilis. Again, the data with doxy, overall, not much has changed since 2014. These are smaller studies. They are retrospective in nature. And no, not necessarily including control groups. Some of them do. And then I guess I'll highlight this one in the corner that showed that perhaps doxycycline is not as efficacious for treatment of late syphilis, but the data, again, were pretty small numbers. So our use of doxycycline really, I think, comes from a lot of clinical experience and like several of these studies that are overall reassuring that doxycycline has high efficacy, but are not large randomized controlled trials. Okay, so now flash forward, the BPG shortage is over. You are seeing a 36-year-old cisgender woman who has HIV. She has a low CD4 count of 152, percent is 10, viral load is 53,000. She's been off ART for a couple of years, and she's complaining of some vulvar warts. And you are concerned for condyloma. You don't remember if this is condyloma lata versus acuminatum, but you remember that one of those is associated with syphilis. And so you order appropriately an RPR, which returns at 1 to 128. How would you treat this patient? A, 2.4 million units of BPG, B, 7.2 million units of BPG, C, IV penicillin for 14 days, or D, something else. All right, we hit 100. We hit 100, so I'm gonna move forward. Okay, good. So everybody knows 2.4 million units of BPG is the appropriate answer. This is condyloma lata. This is also secondary syphilis. So like we were talking about earlier, do the appropriate physical exam. If there are lesions consistent with primary or secondary syphilis, you can treat for primary or secondary syphilis with 1 round of injections versus 3. Condyloma lata are cutaneous wart-like lesions. They can look like HPV-related condyloma acuminatum, and in general, they are quite hard to distinguish on physical exam which one is which. They are typically flatter and they're more moist. Condyloma acuminata have a drier appearance. And then if this patient does move to biopsy on histologic exam, what you would see is epidermal hyperplasia with superficial neutrophils and then this kind of dense or intense dermal mononuclear infiltrate. There is absence of HPV-related coilocytic change. I had to actually look up what that is. It's when the squamous epithelial cells start to have this perinuclear cavitation, and it's just kind of on the way as patients are developing dysplastic changes. But there are some slight differences on gross appearance and then some histologic differences, of course. So speaking of 1 versus 3 doses for early syphilis, I wanted to review this recent study that was presented at ID Week in October. Jody Dion is at UAB. She presented for Ned Hook, who I believe was the principal investigator for this study. It was a DMID trial. And so, as the title would suggest, the primary objective of this study was to compare efficacy of a single dose of 2.4 million units of BPG versus 3 weekly doses for therapy of early syphilis in persons with and without HIV. It was a non-inferiority study, and the main outcome was response to therapy at 6 months. Cure was defined as we would expect with a 4-fold decline in titer. What I will add is we typically give patients up to 12 months to respond when they have early syphilis. And so, and for early latent syphilis, up to 24. And so looking at 6 months is early, but it's still, and I guess I'll add they have 12-month data that they will present soon. But they went ahead and presented this 6-month data at ID Week, and it was an intention to treat, but per protocol analysis was similar. So just looking at the participants, it was 249 participants in total. The mean age was 35. The vast majority were assigned male sex at birth. It was only 3% assigned female at birth. The majority were Black, 62%, 25% white, and 13% Asian or other. And then also the majority, approximately half, had secondary syphilis. I think these percentages are slightly erroneous, but it was about 20% with primary and around a third with early latent infection. And then the majority also were living with HIV, so 61% with HIV infection. And so they gave the results, the cumulative 6-month response by HIV status for people with HIV. Again, this was the majority of the participants in the study, 153. The response with 1 injection of BPG was 76%. Again, this is 6 months, so this is reasonable response rate. And then BPG for 3 weekly doses, the response was 71%. So there was no difference there in people with HIV. And then with people without HIV, 1 injection, the response rate was identical, 76%, and BPG times 3 weekly doses was 70%. So as you can guess, these numbers are so similar. So for the overall, it was very similar to these numbers that I'm showing you here. But no difference really in the people with HIV and without HIV, which is really exciting for us as HIV providers, right? But also no difference with 1 versus 3 weekly injections, which I think we sort of had an answer to this before, but we needed a definitive answer, and now we have it. And so I think in some cases, providers do tend to think, gosh, for my patient who has HIV, more is more. But I think this trial really gets to the answer to that. So particularly in the setting of bicillin shortages, we really can know the firm answer is one dose of BPG for all comers. And so the conclusion of this study was that there's no significant difference in treatment response. I think I've kind of covered this and said most of this, but no difference in 3 versus 1 dose, and no difference in the serologic response to treatment among persons with and without HIV. And so just wanted to put in a quick plug for the Q&A this afternoon, go into further neurosyphilis, otic, and ocular syphilis cases, talk about when and when not to LP, and then talk about serologic non-response, which is kind of what we historically have referred to as serofast, but we're kind of being urged to not use that term so much anymore. And then finally, some treatment side effects. So I think with that, I can jump into Q&A if there are questions that come in.
Good morning. Hi there. Thank you for that talk. I just have a question. This disease I just find so fascinating. But what do you make of the recent MMWR with the 5 women who had ocular syphilis from the same contact?
Yeah. I think I almost added this and I didn't have enough slides, so maybe I'll throw that into this afternoon too for folks who aren't aware. I think that was really fascinating data that was presented. I believe it was Michigan. And so there were 5 women who all came in with ocular syphilis, and they were all linked to a single sex partner who, interestingly, had not had symptoms of ocular syphilis. I think it's really fascinating, and that they could track that is really fantastic public health. We've had other outbreaks of ocular syphilis before that we didn't establish that they were necessarily linked. So I think it's kind of a new experience for us, and we're going to learn a lot from it.
Thank you for your talk. I have a question regarding how in the study was handled the issue of reinfection versus not cured, because many of these people tend to be repeat offenders, and if you could explain how that was handled. The other issue is
Sorry, which study are you?
the syphilis, the
the
cure
last-
6 months.
Yeah,
Yes. The other issue was traditionally we've been taught that syphilitic rashes are non-paritic, and you're telling us that this malignant syphilis is paritic. Any idea as to why the change?
Yeah. So I think that's one of the big conundrums with syphilis, right? That we, and STIs in general, in looking at cure rates, right, and response to treatment, is that it's really hard to distinguish treatment failure from reinfection. And so it's always important to talk to our patients about potential re-exposure. For this study, they really just looked at serologic response. So what you see, the numbers, kind of what you see is what you get. If somebody was potentially re-exposed or reinfected, they would have, and their titer went up, they would have considered them somebody who did not respond to the regimen at 6 months. And then the paritic is an interesting question, and I've kind of gone back and forth with some dermatologists in our clinic before. So the rash of secondary syphilis that is my dermatology friends say don't use the term maculopapular, but we always do. The rash that you typically think of on the trunk and the palms and the soles, we would say in general that's not paritic. I promise I've seen 1 or 2 that the patient complained of itching, and so again, it is what it is. I can't necessarily argue with them, but they definitely had secondary syphilis. But what I was referring to in that case was malignant syphilis that can be paritic, and that's a kind of known phenomenon. But just to distinguish those ulcers from the generalized rash we see in secondary syphilis, those are 2 different things. Does that make sense? Okay. I don't know.
Hi, can you comment on what your thoughts are about the increased use of doxypep and how that might mediate these incredible increases in syphilis?
Yeah, I think we're all hopeful that it will have an impact. It's going to be interesting to see kind of, over the coming years, San Francisco is doing this routinely now. Where I am in Louisiana, the uptake has been much slower. So what's going to be the impact? I think we're all hoping, and we don't have data for this yet, but we're all hoping that the community level, the public health impact on a community level will be there. And even though the disappointing results from the DPEP study in Kenya showed that cisgender women, doxypep was not effective to prevent STIs in cisgender women, I think we're hopeful that if there's enough use in men who maybe have sex with men and women, that there might be an impact among women, and that might help with the congenital syphilis rates too. Because it's all a huge problem, and it's all intertwined, right? Thank you for that question.
I had a specific question about concerns about efficacy of doxycycline in the setting of the penicillin shortage in people who have CD4s less than 200 or who are not on therapy or newly diagnosed.
Yeah, so I think that we have been doing it when we have to. Always we should be following titers, but particularly when a non-penicillin regimen is used, I think we need to be extra cautious. Do you have a working phone number? Can we follow you up to bring you back, to make sure your symptoms have resolved, to make sure there are no neurologic symptoms, to follow that titer? But it's kind of, it's not perfect, right? But it's doing what we have to do to reserve those bicillin doses for pregnant women.
Do you think it's reasonable to treat them if you have it on hand that way, or do you think that this is a group where if you have it on hand, it may be reasonable to treat them with penicillin instead of doxycycline?
Yeah, so where we are with our clinic now, we have more doses. We're still sort of triaging. So the specific case, we're looking at kind of who's the patient, how symptomatic are they, and what's the clinical nature of what's going on, and determining what's best. Since we have more, but we don't have an abundant supply.
Okay, thank you.
May I ask one more question?
Sure.
Given that this organism seems to elude our immune system, do we have any hope of a vaccine moving forward, or what's going on in the vaccine world with this organism?
Yeah, so I honestly don't live in this world exactly, but I do know that there is hope that they are working on development of vaccine. It's not going to be in the near future, but perhaps in our lifetimes. So I think there is some hope, and it's something that folks are working on.
Okay, I have an entire textbook of questions here. We'll get to about 10% of them, but I'll hand them to you, and you can take them to the breakout later today. So in no particular order, there's a push to switch to the reverse algorithm from the traditional algorithm, and thoughts as this pertains to MSM. So I guess in terms of testing algorithms, do you do FTA, RPR? How does that?
Yeah, so I mean, I think unfortunately or fortunately, the type of testing algorithm, so hopefully most folks are in the room are familiar with the traditional algorithm, which starts with the non-treponemal test, versus now we've moved a lot of labs for kind of throughput and manpower reasons have moved to the reverse sequence algorithm, which starts with a treponemal test first. And it creates a lot of clinical questions because we see cases that we wouldn't have seen in the past when the RPR is non-reactive or the VDRL. In terms of like which algorithms for specific populations, I'm not sure I know of any data that would speak to the use of one or the other.
Yep.
I'll just say that the reverse sequence algorithm is going to pick up on cases that have gone untreated perhaps, but is a little bit maybe more confusing to follow. But it's the lab that makes the choice, not us. Right?
So this is one of the dreaded neurosyphilis questions, because it can always be a bit of a conundrum. So you've got a young MSM, HIV well-controlled patient who has a headache for about looks like a month, but it's been going on for a while. RPR serum is 1024. The CSF is normal, including the CSF VDRL. With that symptom alone and the high RPR, do you treat for neurosyphilis?
So in that setting, so I think headache's always a challenging one. It's not a cranial nerve finding. It's not meningitis. It's not neck stiffness, and there are lots of reasons to have a headache. I think I would. It's hard to answer when a patient's not right in front of you sometimes, but I think in that situation with a really benign CSF, I would not treat for neurosyphilis.
Right. I think you just mentioned something very important that everyone should focus on, is that if there's any sign of optic nerve involvement, cranial nerve involvement, that's an automatic treat. You don't even bother necessarily to do an LP in that.
So the guidelines would actually say with cranial nerve abnormalities or dysfunction, you still do an LP.
You do the LP and then you treat. Yeah. Okay.
And we can talk about more this afternoon for anybody who's interested, but you don't need a follow-up LP if that patient has either doesn't have HIV or their HIV is well controlled on therapy and they've had an appropriate decline in their non-treponemal titer.
Any opinion on 1 versus 3 bicillin treatments for latent syphilis?
For latent syphilis.
Late latent.
I think in general we're doing 3 for late latent, and we can do, if we can document for early latent that infection occurred within the past year, one round of injections is appropriate.
So this is a fun question. Why is Pfizer the only producer of bicillin?
Your guess is as good as mine. I don't know. But we need more suppliers, right? I think that gets to the heart of the problem.
I guess it's still on patent, right? Okay. So that we've already talked about the reverse algorithm. All right. In this person's state, the Department of Health do outstanding outreach, et cetera, for contact tracing. What's your suggestion for how current syphilis outbreak can help with advocacy? In other words, you do the best you can in terms of finding partners and all that, but yet the numbers still go up. What more can be done?
Yeah, so I think this is really interesting field of research and advocacy and public health interventions, but people are getting really creative. There was a session at ID Week on innovations that would lead us to kind of better control the epidemic, but there's a lot going on. So like Louisiana has a program now where we partner a DIS agent with a nurse so they can treat in someone's home. There's more and more use of mobile health vans all the time. I think we're just huge efforts to raise public awareness that this is going on. If anybody's read the newspaper lately, the discussion about the increase in congenital syphilis is in the news and in the media. So I think people are becoming more aware. It's just a matter of putting the resources where they need to go to create these really kind of effective public health interventions.
Okay, if you dilute the sample for prozone, how can the RPR titer be accurate?
Oh, that's a good question. I think the lab tech has the experience with this, and they kind of consider what they've already diluted, and then they go.
Right, just multiply it out. Yep. So this is about diagnosis of congenital syphilis, and the American Academy of Pediatrics has this table, and it goes from very likely to less likely. And are all those considered cases, or how do they come to that? Do you know?
So I do know that there is an adjudication process, because when they release the data earlier, they go back and they carefully look at it to update it and adjudicate. I do not live, I'm sorry, in the world of congenital syphilis, and so I am not like closely familiar with that process, but I know the process exists.
And I think it's important to emphasize that there can be early symptoms, but there also can be late symptoms in the children, right?
Yeah, and actually there's a lecture on pregnancy later today, I think, where this may come up again. And so, you know, somebody who does OBGYN care might have more insight too.
Do the condyloma lata lesions resolve with the shot of bicillin?
Yes.
They just go away?
They should, yeah.
Okay.
Within a couple of weeks, actually.
Is it possible that a poor RPR response is, well, basically, when you have someone who you've treated and the RPR remains kind of serofast at a high level, like say 1 to 128, what do you do? Is that a reinfection? Is it a failure of treatment?
Yeah, that's a little bit of a loaded question. So come to my afternoon session and we'll talk about it. But there are different strategies for following this over time, continuing to check in with the patient, assess for HIV infection. If they're not HIV infected, you test them again. You evaluate for neurologic symptoms, do neurologic exams. There are many things you could do, but I do think in general, we have come to understand more and more how bad our serologic testing is, and we just put up with it, and we follow folks over time, and we give them an opportunity to respond. So we give them the appropriate amount of time. And if they haven't developed neurologic symptoms, you just kind of sit on your hands and wait, right? Patience is a virtue.
Yeah, so unfortunately we're running out of time, and we can stop your torture exercise here. I mean, I feel like I'm in Fiddler on the Roof and we're posing questions that would cross a rabbi's eyes. So the final one is why do you think the rates are increasing in women? Or rates increasing overall, but especially
You know, I knew
women.
somebody was going to ask that question, and I've tried to give it some thought, and maybe some others who kind of live in the public health spaces know. I think it's poor access to care, and it's drug use, and it's you know, just because rates overall are going up,
Right.
but kind of why cisgender women are being so much harder hit, and the rates have gone up by 50%. I guess I don't have the perfect answer.
Well, and the prevalence is high, and it just breeds it. We got to do a better job of intervention and getting it under
100%.
control. Okay, great. Thanks for putting up with all this.